Hello, this is our presentation for dialectical behavioral therapy for veterans. Dialectical behavior therapy, or DBT, was developed by Marsha Linehan in the 1980s as a derivative of cognitive behavioral therapy. The manual created by Linehan is still the primary material used by therapists implementing DBT. It was mainly developed for clients with suicidal behavior and/or borderline personality disorder because of its attention to dealing with life's problems that can elicit a strong emotional response. DBT recognizes that some people have more difficulty regulating their emotions than others, and we'll discuss the importance of this later in the presentation. Broken down, dialectical means the acting through opposing forces. In DBT, dialectical-based components guide the therapist and the client to abandon extreme positions in favor of a more balanced approach to life. Using what is known to DBT clients as wise mind, clients are taught how to make decisions that balance their rational mind with their emotional mind. DBT simultaneously validates the client's feelings and experiences while still encouraging change behaviors. The behavioral aspect of DBT focuses on assessing problems and situations in the client's life to determine what behavior changes would help them better address their concerns. This is a collaborative, ongoing process. In general, DBT is about helping clients develop the skills to live a life they deem worthy of living. There are several assumptions that ground DBT and are reviewed in the early stages of the process. These include the idea that people are doing the best they can, but might still have difficulty regulating emotions. People want to improve. People need to do better, try harder, and be more motivated to achieve their identified goals. People may not have caused all of their own problems, but they do have the responsibility to solve them anyways. And figuring out and changing the causes of behavior works better than judging and blaming. These assumptions are important for both the therapist and client to remember as they go through the DBT process. DBT is a multimodal approach that contains 4 components: individual therapy, coaching between sessions, a consultation team, and skills training. Most DBT groups conduct skills training in a group setting. However, accommodations can be made to do this individually as needed. A client would have an individual therapist and then a separate provider leading their group. The purpose of individual therapy is to assess the client's life with them and to help them identify problem situations in order to create goals for treatment. Individual therapy is also used to increase client motivation for treatment, as it can be a challenging model to implement week after week. Group leaders guide clients through 4 main skills that DBT utilizes to create change. These are mindfulness, emotion regulation, distress tolerance, and interpersonal effectiveness. This group is psychoeducational, so it has more of a class-type feel to it. These skills are meant to teach clients how to non-judgmentally notice the self and the environment, deal with painful events, recognize and turn unproductive emotions into helpful emotions, and how to modify communication skills so that clients can develop more satisfying relationships. The group format is preferable as clients can learn from one another. And while it's not structured to be a supportive group, clients may naturally feel encouraged by hearing how others are handling this journey as well. The phone consultation aspect was developed to help clients when they leave session. Material may be understood within therapy, but oftentimes, especially at the beginning of treatment, clients need extra support when they leave sessions in order to use the skills successfully. As DBT clients struggle to regulate their emotions and typically engage in high-risk behavior, having support from their therapist or group leader who know them personally is essential to the building of their confidence in using these skills beyond the classroom, so to speak. A community of therapists supports the DBT provider since this model of treatment is incredibly demanding in comparison with some of the other behavioral treatment options. They help keep the therapist centered and add another perspective to aid the therapist and thus the client in figuring out how to address life's problems in therapy. The DBT therapist is ultimately responsible for knowing when to apply these concepts, especially when utilizing consultation and in-the-moment phone coaching with the client. Mindfulness helps a client stay in the present moment, living calmly in the here and now. Emotion regulation helps clients recognize, identify, and understand their emotions. DBT posits that by learning about our emotions, we can decrease their intensity and learn how to let the emotions settle before acting. Distress tolerance teaches clients how to get through highly emotionally triggering situations, and it teaches clients how to self-soothe when they feel upset rather than becoming overwhelmed or avoiding their feelings. Once these skills have been put to use, the client is better able to make a wise decision moving forward. Lastly, interpersonal effectiveness skills help the client to both understand what they need from relationships, as well as how to get along with others in a healthy way that can still satisfy the client's needs. It involves skills such as learning to respect others, listen to them, and learn how to say no when necessary. As part of skills training, DBT includes homework in the form of worksheets and daily self-monitoring, which teaches the client how to be their own case manager. The specific form of self-monitoring used in DBT is known as diary card that lists different behavioral objectives outlined in each of the 4 core skill areas. Through this process, the client becomes more aware of their reaction to situations throughout the week and the behaviors they demonstrate in response. As treatment progresses, clients will be attempting to implement their new skills in order to mitigate some of these intense emotional reactions that they used to demonstrate prior to treatment. In this model, the client and therapist agree to work together to learn and apply these new skills. In pre-treatment sessions, usually 2 to 3 sessions, the therapist and the client create a contract that defines things such as the attendance policy, expectations for both the therapist and the client, and an agreement that the client will not engage in suicidal or self-harm behaviors, as well as any therapy interfering or quality of life interfering behaviors, so that they can learn healthy ways of handling life's problems. The recommended DBT model for adults is weekly treatment over the course of 24 weeks and includes both individual and group therapy. Membership to the DBT group is traditionally open, but the format in this aspect can be adapted to meet the needs of the specific group being treated. Some DBT groups close their sessions but open the group once one skill module is completed. So once they finish distress tolerance, for example, they may allow a new client to join the group before starting the interpersonal effectiveness unit. DBT thrives on a rigid, specific structure in order to be the most effective. Fidelity is measured through the DBT Linehan Board of Certifications assessment. This is a self-assessment that asks DBT clinicians to rate themselves on a scale from 1 to 5 in different categories. Some of these on the assessment include how well the clinician adhered to the weekly consultation meetings, whether the program was utilized to teach clients to self-monitor, and how adjustment worked if the traditional format needed to be adjusted. All programs applying for a DBT certification will be evaluated by this same assessment. And you can actually go on the website and download it for free, and it comes up as an Excel document that I've taken a screenshot of here on this slide, and you can rate yourself from there.
When it comes to using DBT as a treatment modality, there's many strengths that should be considered. DBT is helpful in decreasing male and female veterans' utilization and cost of mental health services. This also includes their hospitalizations. The VA's guidelines for the assessment and management of clients at risk for suicide included DBT as a treatment recommendation. So it is helpful for this population of veterans who may be experiencing multiple symptoms and just lots of different behaviors, which we'll go into a little bit later. Another strength of DBT is that it is evidence-based. It goes beyond mental health illness, and it improves just the overall individual's quality of life. DBT can help reduce trauma, depression, anxiety, and just overall stress symptoms in a client's life. It also helps decrease suicidal and self-harming thoughts and behaviors. DBT has been used in conjunction with PTSD exposure-based treatments and for treatments with clients with complex trauma. This is especially important when we're considering using this as a treatment modality option for veterans. There's also the strength of it being having a group component. So the group component of DBT, it allows the clients in the group to learn and practice skills in a safe and supportive environment. So the environment will be set up by the clinician utilizing DBT and making sure the space is safe, it's supportive, and that everyone there understands those at the beginning before the sessions even start. And there's also diversity within DBT. So research has found that the effectiveness of DBT can reach far and wide, and it can generalize to clients of different ages, genders, sexuality, race, ethnic groups. It can cross all those lines and be kind of personalized for people in all of those groups. Lastly, DBT addresses many issues that veterans may experience. For instance, veterans account for 20% of suicide-related deaths in the U.S. This goes back to DBT being evidence-based and helping decrease some of those suicidal and self-harming thoughts and behaviors. Up to 21% of veterans in the VA are diagnosed with PTSD, and emotion regulation difficulties can be related to some of the impulsivity in veterans with PTSD. And we will get into more of the emotional regulation difficulties that veterans might experience and how DBT can address those and come alongside a client later on in the presentation. There are also some weaknesses to consider when initiating DBT as a treatment modality. To begin, DBT has not yet been disseminated nationally across the VA. Unlike treatments for disorders that are more prevalent in the VA, such as depression and PTSD, DBT has not yet been disseminated to use as a treatment modality for these issues. One reason is possibly the complexity and intensity of DBT and how this does not always fit easily into the routine that the VA clinic has structured and the settings that they already are working in. Being understaffed and working to address maybe some more common mental health issues without using DBT is the main focus. But as they work to increase veteran access to care, hopefully DBT will be used more in the future. Second, there is a time commitment with DBT, so it requires a significant amount of time. This is both from the client and the patient and the clinician. So this can be a weakness to those who maybe don't have enough time to commit to this treatment modality, or possibly just don't want to, or are looking for something shorter. So this could be a barrier as well. There's also a lot of homework that's involved with DBT that may not be well suited for everyone, especially when working with the veteran population. We have to consider how this homework may affect them in their life outside of the VA, or how this may trigger some of the PTSD that they deal with. There is no formal trauma processing within DBT. And this may be a necessary component of treatment for some of the clients to recover from traumatic experiences, just on an overall basis. And so when we're working with veterans, they may need this formal trauma processing that DBT doesn't necessarily offer. So this could be a weakness within this treatment modality. We also want to look at the religious factors Certain facets of DBT are derived from Eastern religious philosophies. So some clients who may have Western religious values, they may object to the Zen teachings. So we want to take that into consideration. And we'll touch on that a little bit more here in the next section. When using DBT, we want to consider cultural adaptations. So the first one that we want to take into consideration is language or terminology. DBT, like we mentioned on the previous slide, uses homework. This could be a workbook with handouts for clients. And so one of the more obvious needs that we may need to make culturally is in the language of the training manual or on the homework sheets. So if we have homework assignments and they're only written in English, we need to take into consideration that we need to make an adaptation for other cultures as well. These need to be offered in other languages. And we also want to take into consideration those who may not be able to read and take into consideration how we would assist them so that way they are still able to participate in DBT. When it comes to terminology, we also want to consider the population we're working with. So if we're working with adults or adolescents, maybe some of the terms we use or the way we talk about things in the homework or in sessions may just want to be worded differently depending on who we are speaking to. Second, duration and frequency. This is another area that we want to consider for cultural adaptations. Like we mentioned again, time, there's a big time commitment. So as clinicians, we want to use this approach with multiple populations, but with this extended time frame, it could become prohibitive in some settings and maybe take more time in other settings. So we don't want to overlook how adjusting this time frame, depending upon the culture we're working in, could affect the treatment outcome. So for instance, one example would be maybe we live in an area where people move in and out of quite frequently and they're not there long. Maybe we need to think about the time frame that we're working this as opposed to maybe we're working in a town where people are born there and they die there. Those are very different levels of frequency and the duration period that we could look at. So we want to take into the culture area-wise that we're working in when we're using DBT. Next is religion. Like we mentioned in the last slide, it does have roots, DBT does have roots in Zen. So we may need to change up some of the homework assignments for those who may not be comfortable using Zen practices. We always want to respect the client's values and their religious preferences. So if a client discloses to us that they are uncomfortable maybe participating in a Zen practice, then let's think of other ways that we can culturally adapt to their preferred religion. This could be prayer, meditation again, maybe writing, yoga, maybe spending time in nature, etc. There's many options that we could take into consideration, and ultimately we could work this out with the client and alongside of them, so that way we are being culturally sensitive and adapting to the client. There are examples where DBT has already been culturally adapted. So for instance, Nepal actually used DBT in nature. So nature is a big part of their culture. And so they decided to take DBT and during their group sessions, practice outside. This really helped their clients connect and really understand the point of DBT and the root, and had great outcomes for them in the end. Also, when we look at the Latino culture, we think expression, emotionally, just emotionally being expressive. but yet there's this core principle in DBT of emotional regulation. So this may come up as like a cultural conflict during treatment, but it's essential that we as clinicians understand how to address emotional regulation, um, and allow the client to feel culturally how they would normally feel, while also understanding emotional regulation on the therapy level that we want them to do while keeping their culture in mind. Lastly, we also want to take into consideration this example that has been found in Asian countries. So one modification they made was in the homework assignments. So Chinese culture emphasizes structure, education, and this is something that DBT skills have. So the clinicians in this practice in particular felt it was appropriate to modify more of the interpersonal effectiveness skills, such as having this indirect communication and maintaining harmony in relationships. It just helped adjust the content and the application of DBT homework, and made it appropriate for their culture and this skill. So the results of the cultural adaptation of DBT as an effective individual therapy intervention with the client really helps when we adapt it to their culture and allow them to be part of the process when we're creating this treatment, instead of just saying, here's DBT, you're going to work for it. No, we're going to make it work for you. And that's how we can be culturally competent with others while using DBT.
Recommendations for DBT therapy. So since DBT therapy is about bringing concepts together, opposite concepts together, such as change and acceptance, DBT is also known to help clients achieve goals, improve well-being, and have an effect that is lasting of positive change. So studies have found that DBT is effective in treating borderline personality disorder and suicidal behaviors. There's also evidence that suggests that DBT is known to treat substance use disorders and populations with eating disorders, self-destructing behaviors. I think that regardless of one's mental health diagnosis, DBT can help most, regardless of such. So I would recommend DBT for most populations, especially those with anxiety or depressive diagnosis and substance use. Also for veterans with PTSD or experiencing emotional regulation or not being able to regulate their emotions. I would not suggest DBT for people who do not have reliable transportation or have a mental health diagnosis that is untreated, such as like paranoid schizophrenic, especially if they are not taking medication for it, which I would say for most mental health diagnoses that require medication and the client's not taking medication for it, I think it's going to be very hard to do any type of intervention, especially DBT. I also would not recommend anyone do DBT that cannot make the commitment to the time that it requires. On average, DBT is anywhere from 6 months to 12 months. So it's a long commitment, and you're looking at a group meeting once to twice a week. So it's a long process. Most people may hear that and probably won't commit to that. However, some are are open and have the time to do it and are able to do it, then I would suggest DBT. So since DBT can be known to offer a structured environment, I think that for people who are real emotion driven or have anxiety disorders or substance use disorders, it's hard to have structure, and I think that can be very beneficial. And then like the population that I would highly suggest DBT for is the substance use population. Since the substance use population, in my experience working with this population, they're real emotion driven. They have damaged relationships. They're hopeless of any way of life that doesn't involve drugs and alcohol. So they feel like they have no purpose in life. Most of the clients that I've come into contact with, they have low self-esteem, damaged relationships, and as a result, they are full of emotion. And I like to think of it as like this emotional barometer that can only hold so much, and eventually it just pops and blows up. And it looks like resentment and fear and anger, guilt and shame, and drugs and alcohol is a temporary solution for that. And they continue to drink and use, and then as a result, their problems just begin to pile up on them, getting bigger and bigger. Well, once the drugs and alcohol are removed from the person, I would only suggest that DBT be used for the substance use population, people that have detoxed. If they have not detoxed, I find it pointless to do any type of therapy intervention. Only once the drugs and alcohol are removed. However, the mindfulness skills and the emotional regulation, distress tolerance, and the interpersonal effectiveness are all things that the substance use population will lack. So I would highly suggest and recommend DBT for the substance use population. Recommendations for DBT therapy. So